Welcome. My name is Dr. Yaariv Khaykin, and today I'm going to answer some common questions about atrial fibrillation. Okay, let's get started. The first question, that this webinar is now being recorded. All right. So the webinar is available online. The previous webinar is as well. It has been shared with previous participants. And if you go to this QR code, it will take you to my Linktree site, which gives you access to the webinar content, as well as a number of other resources for patients with atrial fibrillation, as well as to their physicians. Let me go to the next question. I went into atrial fibrillation during a provocative acetylcholine infusion challenge during an angiogram. Well, it's an interesting one, and I picked it, even though it's very rare. I don't know how many of my patients would have had an acetylcholine infusion, which is typically done at the coronary physiology clinic. Acetylcholine is a neurotransmitter for your parasympathetic nervous system. And that's actually quite important in atrial fibrillation. So as most of you know, in the vast majority of patients, atrial fibrillation starts at night. Patients complain that when they go to sleep, they start feeling palpitations, or they wake up in the middle of the night with palpitations. And a lot of the time I hear, well, I went to sleep, it started, I woke up, and I was no longer in atrial fibrillation. And we know from multiple studies that the parasympathetic nervous system, part of your autonomic nervous system, is what typically triggers atrial fibrillation in a lot of patients. The way the nervous system works is, you have part of your nervous system that allows you to, move and go about your work and do, things consciously. Then there is the autonomic nervous system that's controlling your breathing and your heartbeat and other kind of important background functions of your body. That has kind of conceptually two parts: your sympathetic nervous system, and that's your adrenaline, fight or flight response. You see a tiger, you run away. And then your parasympathetic nervous system, which is supposed to make your body rest and relax and kind of recover before the next burst of activity. And acetylcholine is a neurotransmitter. It's what your parasympathetic nervous system uses to affect its end organs. So for it to affect your muscles and your breathing and your heart rate, et cetera, it uses acetylcholine. So during this particular procedure, you get given acetylcholine, which is sort of like your parasympathetic nervous system going into overdrive. And conceptually, it may cause an episode of atrial fibrillation. Although, if you have it, it doesn't necessarily have any prognostic implications, although the data is being looked at right now. Where it is important for our patients, again, is that perfect storm. When you switch over from sympathetic overdrive to parasympathetic overdrive is when a lot of patients tend to go into atrial fibrillation. So if you're one of those people who have, a really busy day at work, and then you go for a workout, and then you sit down and have that one huge meal of the day and top it up with a glass of wine and an espresso, and then you go to sleep, that's kind of the worst of all possible worlds, because you were super adrenaline driven this entire time. Then when you eat that big meal, your body takes care to digest it and then absorb the nutrients. And what happens then is kind of like your snake digesting, whatever it ate. There's this whole concept of the snake sort of going to sleep while it's digesting. Well, that's exactly what happens to you. A lot of your blood gets diverted to your splanchnic circulation. That's the blood flow to your gut. And so it comes out of your central circulation, and your body wants you to rest while you're digesting. Caffeine gets you to lose some fluid. It's a diuretic. It makes you go pee. And caffeine acts for about the first half an hour or so after you've had your espresso, and then theobromine kicks in, your blood vessels dilate, and that's kind of another part of the parasympathetic nervous system coming into drive, and then you go to sleep and turn on the parasympathetic nervous system all the way. So the switch over where you go from adrenaline-driven state to acetylcholine, so to speak, driven state, are very relatively rapid transition, can sometimes throw patients who are otherwise predisposed to atrial fibrillation into their arrhythmia. And trying to avoid it, such as breaking up your meals into smaller meals, having those meals over a longer period of time, preloading your calories in the morning or at lunch as opposed to at night, not eating close to going to sleep, not exercising vigorously prior to going to sleep, and certainly, lots of advices we give our patients related to caffeine and alcohol may all help prevent that rapid transition from sympathetically driven to parasympathetically driven physiology, and potentially reduce number of atrial fibrillation episodes in those patients. Does genetics play a role in atrial fibrillation? Another good question. While most of our patients who have atrial fibrillation are in their 60s and 70s, and with age, atrial fibrillation becomes very, very, very common. We do occasionally see patients as young as 16 years of age with atrial fibrillation, and I've ablated patients as young as 18 for atrial fibrillation. We do have access to genetic counseling for some of those patients, and are able to send patients for younger who have atrial fibrillation for genetic testing, as well as test their family members, typically for patients who have known history of atrial fibrillation in their family. At this point, prior to this webinar, I connected with our geneticist, Dr. Michael Golub, who also sees patients at PACE for us. And my understanding at this point, there are about 5 known genes that are associated with atrial fibrillation, but at this point, there are no specific therapies for those patients. So it's still in research state. And certainly, if you have an interest, if you have a number of patients or relatives with atrial fibrillation, if you're a young patient with atrial fibrillation, bring it up. More than happy to refer you for genetic testing. But at this point, again, it's in the research as opposed to clinical domain. Can cancer trigger atrial fibrillation? Well, we very frequently see episodes of atrial fibrillation in patients who are sick. When you are sick, you may not be drinking enough fluids, you may not be eating well enough, your electrolytes may not be perfect, your potassium may be low, your magnesium may be low, you may be underhydrated, and all of those are well-known triggers for atrial fibrillation. In addition to that, any inflammation around the heart, the coverings of the heart, the veins that drain blood from the lungs into the heart, any direct inflammatory process could also potentially cause atrial fibrillation. And that does not necessarily predict you having further atrial fibrillation down the road. Examples may be, really bad pneumonia triggering atrial fibrillation. Or in our case, we see a number of patients who may have atrial fibrillation around the time of surgery for tumors in their chest, potentially in direct contact with the heart. But even if they're not, any surgical manipulation in the chest or inflammation after surgery in the chest may trigger atrial fibrillation in some patients. And of course, we see a lot of atrial fibrillation in patients who have heart surgery, particularly surgery for valve disease, but even bypass surgery. So any direct manipulation of the heart, coverings of the heart, and the area around the pulmonary veins can certainly lead to atrial fibrillation above and beyond the risk of atrial fibrillation related to significant fluid and electrolyte shifts, which may happen in patients who suffer from conditions like cancer and other inflammatory conditions which may affect the heart. Can stress, diet, and exercise trigger atrial fibrillation? What can I do to prevent AF recurrence? So I'm going to go through a few slides here, but certainly it is known that in some patients, stress and recovery from stress, so stress itself is kind of an adrenaline event. And then as stress passes and you recover from it, that's the parasympathetic acetylcholine type of driven event. Certainly in some patients, stress can lead to episodes of atrial fibrillation. Again, it's questionable whether it's the adrenaline stage or the recovery stage. Empirically, it's likely more the recovery stage from stress rather than stress itself, but the two come kind of hand in hand. On the diet side, certainly there is association, particularly between obesity and atrial fibrillation, as well as diet that may be short in electrolytes or fluids. So if a result of being on a diet, you run short of magnesium, potassium, you become underhydrated, all of that can contribute to your risk. Exercise is an unusual trigger. We have seen exercise more as a trigger in some of the younger patients, particularly somebody who's 16, 18, 20 years old. In older patients, we typically don't see exercise as a trigger for atrial fibrillation. And if we do, it's extremely rare. And so what can I do to prevent AF recurrence, which also involves some of these other questions? Well, atrial fibrillation is a systemic condition. Again, there are probably a number of different patients which manifest with atrial fibrillation, but have potentially different triggers and somewhat different mechanisms. But that's where it's very important to address it holistically. So in patients with atrial fibrillation, we need to provide medical management. We need to make sure that, as I described in the previous webinar, we need to make sure that if appropriate, they're on blood thinners to prevent stroke, that we make sure that the heart rate is not too fast or too slow, that we try to keep them in rhythm if they have significant symptoms related to the arrhythmia, palpitations, fatigue, shortness of breath, dizziness, chest discomfort. So medical management, and related to that, ablation to try and permanently get rid of atrial fibrillation, or at least significantly reduce the likelihood of you having atrial fibrillation, are very important, but not enough by itself. Patients with atrial fibrillation need a lot of other supports. Obviously, they need support from other caregivers, their family. A lot of time, atrial fibrillation may affect your ability to work. You may be on disability. It may affect your ability to travel without the risk of going out of rhythm and then having to seek medical attention in a foreign country, where it may be difficult to find or it may be expensive. It's very important that you have a family doctor or a nurse practitioner that looks after your other risk factors, helps you with your weight management, blood pressure management, diabetes management, etc. Very important to have support from your wellness coaches and, dietitians, nutritionists, etc. And that's where we partnered up with MyView. MyView is a dedicated virtual coaching service for our patients that gives you access to all of those services and that type of coaching, where you get access to a dietitian who can help you improve your diet, potentially lose weight if necessary. We have access to health coaches, you have access to psychologists. There's a huge overlap between anxiety, depression, and atrial fibrillation. We did a study a few years ago where we looked at patients who were waiting for atrial fibrillation ablation, and we administered standard questionnaires with the aim of diagnosing anxiety or depression in these patients. And then we administered them again after ablation, and we found that before ablation, about half of the patients had clinically diagnosable anxiety or depression, and the burden of that declined tremendously after ablation. So mindfulness meditation, access to a psychologist may be very helpful for a lot of these patients. And exercise is very important as well. A lot of patients with atrial fibrillation are afraid to exercise because they're afraid to go out of rhythm. Again, that's relatively rare. Those with persistent atrial fibrillation and atrial fibrillation all the time may not be able to exercise, because so long as they are in atrial fibrillation, the heart rate may go really rapid, really quickly, very early into exercise. And so support from an exercise specialist would be extremely important for those patients. And also peer support. So one of the things we've been working on is trying to establish peer support groups through MyView, where you may be able to, with appropriate privacy and confidentiality consent, interact with other patients who also have atrial fibrillation, who may have similar experiences. May be important for somebody who's considering undergoing ablation or other procedures for atrial fibrillation to connect with another patient who's already gone through it. I touched a bit about obesity and atrial fibrillation. There is a clear association, both from animal research as well as human data, that being overweight does increase your risk of having atrial fibrillation, and that losing weight in those patients may help prevent atrial fibrillation. We're seeing some of that. There haven't been really any dedicated studies to specifically look at that with some of the new agents coming on the market, GLP agonists such as Ozempic, but kind of secondary data from Ozempic and other studies of GLPs is showing a reduction in episodes of atrial fibrillation in patients who are able to lose weight. And it's multifactorial. It's weight itself. body fat is an endocrine organ and potentially directly contributes to the development of arrhythmia. But your entire cardiometabolic profile changes. As you gain weight, your cholesterol goes up, your blood sugars go up, you become relatively insulin resistant, and may eventually develop kind of formal type 2 diabetes. You develop sleep apnea, your blood pressure goes up. And all of those are also independent risk factors for atrial fibrillation. So weight is at, I would say, at the bottom of it all about the base. Well, maybe not all, but a lot of it is related to weight. And it's very important for patients with atrial fibrillation to target a healthy weight in an appropriate medically supervised environment with access to dietitians and coaches. Sleep hygiene is very important. As I mentioned, sleep apnea is one of the most important contributors to atrial fibrillation. During sleep apnea, the patient stops breathing multiple times in the middle of the night because they go into deep sleep, muscles around the throat collapse, and they cannot take a breath. What happens is the oxygen levels in the blood drop, and body starts making hormones such as adrenaline, noradrenaline, to get the patient to either completely wake up or partially wake up enough to be able to take that breath. And every time this happens, every release of adrenaline, noradrenaline at night is a hit to the cardiovascular system. Every time it happens, the blood pressure goes up with all the antecedent, effects. Risk of stroke is increased in people with sleep apnea, et cetera, et cetera, et cetera. Hydration, mentioned this as well. We typically counsel patients to aim at about 2 liters a day of non-alcoholic, non-caffeinated beverages in order to maintain adequate hydration. Maintaining adequate hydration will also, to some extent, keep your parasympathetic nervous system at bay. We talk about reduction or ideally avoidance of alcohol and caffeine, and it's typically not replacement of caffeinated beverages with decaf beverages. Decaf may contain some chemicals used to extract caffeine and may still contain some caffeine. There had been studies comparing patients who went on decaf versus caffeinated coffee, for instance. And to my knowledge, none of those studies showed any clinical benefit of decaf over caffeine. So it's really all about avoidance or at the minimum reduction in the intake of these beverages. We talk about exercise and how patients develop exercise routines that are appropriate and individualized to that patient, healthy weight management, mindfulness. And, a particular electrolyte that's very important is magnesium and to some extent potassium. A number of our patients are also on diuretics. These diuretic medications, aside from lowering your blood pressure or reducing the amount of fluid, if somebody's got fluid on board that may go into your knee, ankles or your lungs, along with the fluid, the diuretic medications also reduce your levels of potassium and magnesium, and that may be important as a potential trigger in atrial fibrillation. These electrolytes should be monitored and should be replaced as necessary. This is our wellness team. Many of you have met this great team of healthcare professionals. Again, you can see them through the MyView site, and they're there to help you with your atrial fibrillation. When you're in the program, you get access to your own dashboard using our virtual care tools, where you can interact with your coaches. You can document, trackers such as your weight, blood pressure, et cetera. Be able to track it over time, allow the wellness specialist to track it with you over time, et cetera. And we also are able to push information in our health library to you, including care plans that could be individualized to your care. More questions? Well, what is the risk of atrial fibrillation following ablation? I'm going to address all of these kind of in the next few slides. So the questions are, what is the risk of AF recurrence following ablation? If you had an ablation and still have some atrial fibrillation, what do you do? Does persistent atrial fibrillation benefit or not benefit from ablation for cardioversion? Why does AF recur late after ablation? So let me take you through that. So based on our data, we've been doing ablation in February. It's been 20 years since we've been able to offer ablation for atrial fibrillation at Southlake. And over the last 12 years or so, we've been seeing these patients through PACE. we've collected data on every single patient. We have now done somewhere around 4,000 ablations or so over time. And based on our data, our success rate was a single procedure is around 75 to 80% of not having atrial fibrillation. There is about a 20 to 25% failure rate of each successive ablation. And so typically when I talk to patients about ablation, I say that, the success rate of one ablation is 80%, 20% of the patients need a second procedure, 5% may need a third procedure. And we've done a handful of fourth procedures, although, again, it's kind of diminishing returns if you look at the overall success rate for the original population coming to us for help. Paroxysmal atrial fibrillation is certainly less likely to occur after ablation. The success rate of ablation and paroxysmal atrial fibrillation is about 5 to 10% higher than in patients with persistent atrial fibrillation. When I talk about success rate, we talk about zero atrial fibrillation. Now, there are a number of patients who have failed in that they still have some atrial fibrillation. But when we did a study on this and published on it, when we look at symptomatic burden of atrial fibrillation after ablation, we found that based on the patient's experience, patients who continue to have some amount of atrial fibrillation after ablation typically have much less atrial fibrillation, and the burden of symptoms related to atrial fibrillation goes down by about 95%. So if you're a patient with persistent atrial fibrillation, for instance, and you are in atrial fibrillation all the time before ablation, and your heart muscle is not working so well, you're tired, you're not able to exercise, and then after ablation, you have an episode of atrial fibrillation, let's say, once every 6 months, once a year. Technically, it's a failure in that you're still having atrial fibrillation. Practically, you're spending much less time in atrial fibrillation, and most of the time you're feeling relatively well. And that's been our experience with our patients who we've been treating for the last 20 years. Mechanism of recurrence and time to recurrence have changed over time. When we started doing these procedures 20 years ago, technology was not as good as it is right now. We certainly haven't had as much experience. And so we found that most of the recurrences happened relatively early after the first ablation, and most recurrences had to do with either incomplete isolation of the veins or relatively early recovery of connection into the veins. As the technology has gotten substantially better over time, and we've gotten a lot more cases under our belt, a lot more procedures under our belt, the recurrences have also changed. So the risk of having a recurrence in the first few months or in the first year has gotten substantially lower than it was several years ago. And we hardly ever see recurrence of conduction into the veins. Most of the time, the patients who come back with more arrhythmia and come back and need further ablations, we find that they have what we call substrate or electrically abnormal tissue elsewhere outside of the veins. And that's very individual. There are some patients who have it in the left upper chamber, some in the right upper chamber. And again, some could have it in the front of the chamber, some on the back of the chamber. A lot of the time, it's very difficult to pinpoint those areas out when we do our first procedure. Our first procedure is strictly to address the veins. We do look at electrical substrate elsewhere, and if we find specific patterns of abnormal electrical substrate elsewhere in the upper chambers, we do ablate them in the first procedure. But a lot of the time, those are not apparent until somebody has a recurrence come back, and then we see that the veins are fine. It's some other area in the upper chambers that's responsible. And that's typically what's responsible for the late recurrences. So patients who've had an ablation, some number of years ago, and let's say got, good 7 or 10 years out of the first ablation, they come back with an arrhythmia, we go in, we typically don't find any recurrence in the area we had previously ablated. And we typically find new abnormal tissue that wasn't present 7 or 10 years ago in some other part of the heart. So I think I covered everything on this slide. Another important distinction is that there is what we call a blanking period. I think we have spoken to all of you about it when we talk about ablation, but recurrences of arrhythmia in the first few weeks or months after the procedure do not necessarily predict long-term outcomes of the procedure. So if you're having arrhythmia, a day or a week or 2 weeks after your ablation procedure, that recurrence is likely related to inflammation around the heart after ablation, and it doesn't mean you're going to have more arrhythmia down the road. When we looked a few years ago at all the patients we'd ablated at that point in time, it was probably about 800 or 1,000 patients at that point in time, we found that any arrhythmia recurrence in the first 23 days has zero predictive power to tell us whether or not you're going to have more arrhythmia down the road. As you go beyond the first months, there starts developing some association between those recurrences and late recurrences. But even if you're having some arrhythmia at 3 months after ablation, only about half of those patients will have arrhythmia after the first 3 months. So even at that point in time, a recurrence doesn't necessarily suggest that you will continue to have arrhythmia. And then if you come back and you clearly have arrhythmia after the first 3 months, then that's a joint decision-making process. We, again, go back to sort of square one and say, well, we could treat you with medications, we could treat you with another ablation, we could treat you with what I'm going to discuss in the next few slides, AV junction ablation, pacemaker placement, depending on, who you are, what your other health concerns are, et cetera. Now, when we talk about atrial fibrillation and take all of this into consideration, it's also important to keep to what our definitions are. So we've had some questions about persistent, and I already talked today about persistent versus paroxysmal atrial fibrillation. But just to make sure that we're on the same page, we call arrhythmia paroxysmal when it lasts more than 30 seconds, but less than 7 days, and it converts on its own. Now, every so often, I see referrals and Holters from other physicians that say the patient had 5 seconds of atrial fibrillation. 5 seconds is not atrial fibrillation. By definition, for us to call something atrial fibrillation, the episode has to be at least 30 seconds in duration, or it's not atrial fibrillation. Persistent atrial fibrillation is atrial fibrillation that lasts without stopping for more than 7 days, but less than a year, or atrial fibrillation where we have to stop it every time the patient has an episode, where we have to stop it either with cardioversion, with an electric shock, or with medications. And then long-standing persistent atrial fibrillation is atrial fibrillation that's uninterrupted for more than a year, and permanent is atrial fibrillation that persists despite attempts at treatment. Now, we know that from studies that we've participated in fact, last year, we were part of a consortium that published in New England Journal of Medicine on progression from paroxysmal to persistent atrial fibrillation, where we found that if we do an ablation early as opposed to trying medications first, the likelihood of you progressing from paroxysmal to persistent atrial fibrillation gets much better. So really, most of the bang for the buck is in preventing disease progression or slowing disease progression and treating you when you are paroxysmal, when the arrhythmia comes and goes. That said, we clearly have evidence that patients with persistent atrial fibrillation, although they don't do as well as paroxysmal patients, do definitely benefit from ablation. And even patients with long-standing persistent atrial fibrillation, some of you may remember that years ago, there were a couple of studies, including a big study called AFFIRM, where patients were randomly assigned to treating to try and maintain rhythm or achieve and maintain rhythm versus treated with just rate control. And, when they did a body count, they found that if you look at strokes and deaths, there was not much difference between the two approaches. And then the decision was made, well, there's really no difference, and therefore there's no point trying to get somebody into sinus rhythm. Sub-analysis of that study showed that patients who were able to get to sinus rhythm and were able to maintain sinus rhythm did substantially better. Mortality was better, quality of life was better among those patients. We just didn't have good tools to get you to sinus rhythm and to get you to maintain it. And so empirically, most patients who have an episode of persistent atrial fibrillation, I personally believe that we should give them an attempt at cardioversion and an attempt at maintaining sinus rhythm. I have had patients who've been out of rhythm for years. They were cardioverted and they stayed in normal rhythm on some medication or following ablation for years and felt substantially better. Obviously, that does not apply to everyone. And so these decisions have to be individualized. But just the fact that you have persistent atrial fibrillation is not a reason to leave it alone and not treat it. And so we typically offer at least one go at cardioversion to see if getting into sinus rhythm and staying in sinus rhythm improves your quality of life. Now, I don't believe I covered it at the time of the last procedure, but what is a cardioversion? So there are two types. One is chemical cardioversion, where we'll give you a medication that may convert you to sinus rhythm. There are some patients with paroxysmal atrial fibrillation whom we treat with pill-in-the-pocket approach. We give you a medication and tell you to take it, first under observation, and if it works and you don't have any side effects, you could take it on your own to try and convert your episode of atrial fibrillation to make sure that it's short and that you don't need to go to a hospital. And then there is electrical cardioversion. To be honest, in general, we prefer electrical cardioversion. It's done under observation. It's clean in that we're not mixing a whole bunch of medications in you, etc. With electric cardioversion, we bring you into the hospital electively. We do elective cardioversions several days a week in the morning before we start doing our other procedures. Or you could come into the emergency room and have a cardioversion done. With a cardioversion, we place pads on your chest, on the front and the back, and then we deliver an electric shock while you receive a brief general anesthetic. With the electric shock essentially stops all cardiac activity with the idea that normal activity will prevail and take over from the arrhythmia. And generally, electrical cardioversion is successful 95% of the time in getting you to rhythm, but you won't necessarily always stay in rhythm depending on why you have an atrial fibrillation, what your triggers are in the first place. It's an extremely safe procedure. I always quote a very small risk of stroke. We always do it after you've taken blood thinners for a month, have a transesophageal echocardiogram to make sure you don't have a blood clot, or if your atrial fibrillation clearly started within the last kind of 12 to 24 hours. Extremely successful, very safe. Patients come in, have it done, go home about an hour later. It does not prevent you from having further arrhythmia, unlike ablation. So cardioversion is sort of a temporary treatment to restore your rhythm. It doesn't necessarily help you stay in rhythm. Now, I mentioned that for some patients, we need to do a transesophageal echocardiogram, and the reason we do it is to make sure that there is no blood clot in this area called the left atrial appendage. So what is a transesophageal echocardiogram? It's an ultrasound of your heart. We do it from a probe that you have to swallow, and that sits in the foot pipe, your esophagus, right behind your heart, looking with an ultrasound ray into your heart. We again do it under anesthetic, so you don't feel and remember any of the procedure. And typically, we're set up to do both the test and the cardioversion in the same sitting. So you only go to sleep once and get this done. We typically do it for patients at particularly high risk of stroke, patients who have not been on blood thinners long enough or have not been taken an adequate dose of blood thinner long enough, where the arrhythmia has lasted longer than sort of 12 to 24 hours. This left atrial appendage, a little cul-de-sac on the left upper chamber of your heart, is the spot where the blood clots tend to form. And transesophageal echocardiogram allows us to see this very well, to make sure that you don't have a blood clot in the heart before we give you a shock and potentially cause a stroke. Now, if you have this done, it's very important for us to know if you have any difficulty swallowing food, any neck problems, or any abnormalities in your food pipe before we stick the probe down. So please do not keep it a secret. If this is something that we offer to you, we would typically ask you about it, and it's very important to know that it's safe to put that probe in. Generally speaking, so long as you don't have any of these, it's a very safe procedure. And again, we do lots and lots of these. More questions. Explain hybrid ablation, AV junction ablation, and then talk about other new ablation modalities and specifically pulsed field ablation. So first, hybrid AF ablation. There was one patient who asked about hybrid AF ablation recently. What is it? Well, so when we do an atrial fibrillation ablation, we put catheters in through the groin and into the heart and perform an ablation on the inside of the heart. And generally speaking, the energy penetrates through the wall of the heart muscle. Now, some of the studies suggest that there is some substrate, some abnormal voltage that may not be apparent on the inside of the heart, and you have to be on the outside of the heart in order to be able to see it. The problem is that to get at the outside of the heart, you need a heart surgeon. So you need somebody who would go in, open the chest, either minimally invasively or through a sternotomy, have a look at the back of the heart, map it to see what the substrate is like, and then there's been several approaches. One approach to reinforce ablation that we do on the inside of the heart. One of the approaches is to strip the parasympathetic nerve system ganglia, little knots of nervous tissue from the back of the left upper chamber of your heart. As I mentioned earlier, this may be responsible for some of your arrhythmia. In fact, even if we do a regular ablation, a lot of the time we damage those ganglia while ablating on the inside of the heart. And it has potentially some therapeutic implications in that, some patients following ablation find that their heart rate is faster because we've disinhibited their sinus node, your own natural pacemaker that drives your heart. And that faster heart rate, disinhibition of the sinus node, and reduction in the effect of the parasympathetic nervous system of the heart has some empiric evidence to help prevent further episodes of atrial fibrillation. At the moment, we don't offer hybrid ablation. It has been studied and offered in some institutions around the world. There may be some additional benefit, but it's certainly a much more invasive procedure than AF ablation that we currently offer. Now, what about these other questions about AVJ ablation and whatnot? So just to remind you about how the heart works, I already mentioned that you have a sinus node, your own pacemaker, and the top of the right upper chamber of your heart. Sinus node provides electrical activity that then activates the upper chambers. Upper and lower chambers are electrically isolated or insulated, I should say, from each other, except for one wire called the AV node that conducts electricity from the top chambers of the heart down to the bottom chambers of the heart. And so one of the problems with atrial fibrillation is the very rapid and erratic activity of the heart when you're in atrial fibrillation, as this slide illustrates. So in atrial fibrillation, instead of organized activity, the upper chambers start going at 300, 400 plus times a minute, beats a minute. A lot of these beats start activating the AV node and the bottom chambers of the heart at a potentially rapid and erratic rate. You may have symptoms related to irregularity of the heart, but also to the very rapid rate. It's like you're running a marathon 100% of the time. And so a procedure had been devised prior to kind of definitive AF ablation, where we isolate the pulmonary veins on the left upper chamber of the heart. A procedure has been devised to put a catheter through the vein from the groin into the heart and cauterize the AV node to essentially get rid of this conduction. And what happens then is we typically put a pacemaker in first. Pacemaker is a small device the size of a wristwatch that goes under the skin, typically on the left side of your chest, with wires that goes through the vein under your collarbone and into the heart. The pacemaker is used to pace your heart with electricity to make sure it doesn't go too slow. We then put an ablation catheter at the AV node. I'll rewind back to this slide to just illustrate this better. We cauterize this and prevent conduction of electrical activity from the upper chambers down to the lower chambers while using the pacemaker to basically provide every beat in the bottom chambers. The upside, it's a very quick procedure. Typically takes about a half an hour for us to do. The risk is much less than the bigger ablation. The downside is there are some patients, particularly patients with high blood pressure, hypertrophic cardiomyopathy, tight aortic valves, and others really depend on the upper chambers beating properly, which they don't. When you have an AV junction ablation, the upper chambers typically are allowed to stay in atrial fibrillation. You still need a blood thinner, obviously, because the upper chambers are still in atrial fibrillation. You can still form a blood clot in the left atrial appendage. And then the other implication is that now you're dependent on the pacemaker. Every one of your heartbeats is going to be provided by the pacemaker. Now, we know from older studies, we used to put a pacemaker wire down in the bottom, right here, in the bottom of the right lower chamber of the heart. And when we did that, electrical activation didn't follow the normal pathway. Instead of activating through the conduction system, electrical activation would go from the tip of the catheter through the muscle. Now, electrical activation of the heart works in such a way that when we activate it through the conduction system, we activate it about 10 times faster than if we activate it through the muscle. And so with the wire at the bottom of the right lower chamber, the septum, the wall between the bottom chambers, pumps first, and the free wall of the left lower chamber pumps second. And so the whole heart kind of shifts back and forth in the chest, left to right, towards this wire, instead of these two walls pumping towards each other. In some patients, we found that this had really negative implications, and the heart stopped working properly. More recently, we've learned how to put pacing wires right into the septum, right up here, and close to this part of the conduction system. When we do this, what we can do is we can put a wire right here, which would allow the pacemaker to activate the heart through the conduction system. And then we destroy the conduction system upstream, but just a little bit upstream. That allows you, again, you would stay in atrial fibrillation. The bottom chambers would still be dependent on the pacemaker, but at least the activation will be more physiological using what we now call conduction system pacing. There is still the negative implication of the pacemaker itself. Neither the pacemaker nor the wires work forever. And so if you're older and you may need, one or two pacemakers, each pacemaker typically lasts about 10 years, your risk is relatively low. If you're a younger patient and in your 40s, and you may need multiple pacemaker, multiple surgical procedures, the wires may break because of mechanical fatigue, etc. Implications are very different. You can have an infection down the road. The pacemaker may erode through the skin, may need to be extracted, may need to be replaced. And so we typically don't go to AV junction ablation and pacemaker as our first approach. But certainly if you've had a couple of ablations, you're still miserable with atrial fibrillation, we don't think we can help you with any further ablation to try and get rid of atrial fibrillation, AV junction ablation and a pacemaker is an option. Now, a little bit about other ablation technologies. So again, to rewind a bit, we know from this study is from 1998, one of the original studies that looked at episodes of atrial fibrillation and found that 95% of the time, episodes of atrial fibrillation start with extra beats, electrical impulses. So I tell patients sort of like somebody throwing matches towards a can of gasoline, starting from these veins, the veins that drain blood from the lungs into the left upper chamber. This is what it looks like to us electrically. So normal rhythm here on the ECG, one of these veins starts firing these extra beats, and these extra beats throw the patient into atrial fibrillation. Hence, isolation of the veins prevents this from happening, prevents you from having the arrhythmia. Two conventional approaches that are practiced right now, most commonly radiofrequency ablation, where we take a catheter, we walk point by point around the veins and essentially burn the tissue to isolate the vein, create a layer of scar that does not conduct electricity. Second is cryoablation. We put a balloon into each vein in succession, freeze the tissues. Again, your body generates scar around these areas, and the scar prevents you from going out of rhythm. And this is what a map of your heart looks like after ablation. This is the 3D reconstruction of the left atrial chamber. These are the veins coming out of the left upper chamber, and these tags here represent the actual individual point-by-point lesion tags delivered by the catheter. Now, with radiofrequency ablation, we deliver electricity between the catheter and the heart, and the large patch, which is somewhere on your body. Essentially, what happens is between the tip of the electrode and the tissue, as the electrical current goes into the tissue, the density of the current, the density of electrons is really high here. You get resistive heating. The temperature at the interface between the catheter and the tissue goes up, and to 70 degrees plus, and we destroy the proteins. The proteins denature. We destroy the cells in this region, causing damage. And this area then heals and forms scar that does not conduct electricity. A number of other technologies to do the same have been tried, such as high-intensity focused ultrasound, again, heat energy directed by directing ultrasound beams, putting in a balloon irrigated with hot saline, causing a burn around the balloon. A balloon with radio frequency electrodes, where you can sort of deliver radio frequency from a bunch of different sites. These technologies at this point, I don't believe are coming to market in Canada, although all of these technologies have been tried in various geographies. Other technologies that have been tried, and again, are still in trials. In the immediate future, I don't believe they're necessarily coming to the market in Canada, but they might come at some point. And these include a laser balloon. In this case, a balloon is put into each of the veins. You control a sector of laser, and again, you burn the tissue using laser instead of radio frequency in this case. This technology, we've had some experience with at Southlake in research studies, uses ultra-low temperature cryoablation, so cold, but instead of a balloon, we put in a catheter. The catheter has a little stylet, a little driver that we put inside of the catheter that makes the catheter assume these different shapes, and then we cool it down to a really cold temperature, creating a linear lesion. This catheter that looks like a disco ball is actually a Canadian invention from Vancouver. It's called Cardiac Globe. And in this case, this very large device gets placed in the heart, and you can record electricity from these multiple electrodes. You can deliver radio frequency, and it's currently undergoing studies delivering pulse field ablation. It's kind of nice that it's coming from Canada. We've had some experience in research studies at Southlake. It's a little cumbersome to use, but we'll see how the studies pan out. And then technologies that are imminently coming to Canada are these pulse field ablation technologies. This catheter from Boston Scientific, Medtronic, also Medtronic, and Biosense Webster, where these are typically multipolar catheters, and we use a different energy using what we call pulsed field in order to produce the damage to the tissues. These two catheters are either approved or should be approved in the next months or two. This one is probably about a year and a half out. This one is probably about 6 months to a year out. What happens with pulse field ablation is that a catheter is placed somewhere in the vicinity, not necessarily right on the tissue, but close to the tissue, and a series of electrical pulses are delivered, sort of from a device not dissimilar to a defibrillator. And when these little pulses are delivered, they build a field around the cell, which lead to creation of pores, essentially holes in the cell membrane. These holes in the cell membrane allow for flow of electrolytes, such as potassium and sodium, in the wrong direction. So typically, we have lots of sodium in the bloodstream, but very little in the cell, lots of potassium in the cell, very little potassium in the bloodstream. When these pores are open, those electrolytes equalize, and that leads to cell death. Now, interestingly, it leads to cell death without necessarily creating a burn, without necessarily creating a thermal injury, and allowing the tissues to maintain underlying tissue structure. So it's a bit of a cleaner injury. And with that, it's supposed to be a bit safer than radio frequency. The type of energy that's required to destroy different cells may also be different. And so the potential benefit is that we could deliver energy, destroy the muscle selectively. And the muscle is what propagates electricity and potentially these abnormal impulses that cause the arrhythmia. But we don't necessarily destroy the nerve tissue. We don't destroy tissue around the esophagus, the foot pipe on the other side of the heart. We don't necessarily destroy the phrenic nerve, the nerve to the diaphragm, which sometimes is very close to where we ablate. So in studies, it appears to be safer. I think time will tell whether or not it's exactly as effective as point-by-point radiofrequency ablation, which right now is kind of our go-to standard. But we'll know soon enough as these technologies are coming to our center and others over the next few months. And I have a little bit of time remaining. One of the big questions that was asked is, when should someone who had an ablation procedure and is on blood thinners and beta blockers return to playing sports, such as hockey or cycling? And so we have, standard protocols to take somebody off medication after AF ablation. So typically, we stop amiodarone, which has the longest half-life. It's in your body forever. At the time of the procedure, just before the procedure, because amiodarone will take 6 weeks to 8 weeks to wear out and wash out of your system. We try to stop other antiarrhythmic agents over the next kind of 6 to 8 weeks after ablation. We reduce or stop beta blocker and calcium channel blockers if you're stable for about a month after stopping the antiarrhythmic agents. And then we typically follow you about every 3 months with monitors, ambulatory monitors after ablation. We have new technology with these Garmin halters. They're super comfortable, essentially like a heart rate strap. And for our atrial fibrillation patients who need multiple halters, so it's 3 or 4 halters over the first year, we'll let you keep the device and run the monitor off of it every few months while you can still transmit to us if you have symptoms, and we can look at the ECG in between formal monitors for your symptoms. Depending on your risk profile, if you have no arrhythmia and no reason for taking blood thinners, we could stop oral anticoagulation after you're off antiarrhythmic drugs and off of beta blocker or calcium channel blocker, again, unless you need it for some other reason. These are the agents we've already talked about as far as the rhythm and rate control agents. The upside, these medications are helping you stay in rhythm. The downside, they may make you tired, decrease your ability to exercise, etc., but they're not necessarily a reason not to exercise. And while most of the time you can stop the medication depending on your dose, sometimes we have to titrate you off medication as opposed to stop it cold turkey. And that's particularly true of beta blockers. So when you're on sotalol, bisoprolol, metoprolol, if we stop a beta blocker cold turkey, what happens is they block beta receptors for adrenaline on your heart cells. Your body tries to compensate. It builds more and more and more receptors, which are all being blocked. If we just stop your beta blocker cold turkey, now you have a lot of receptors, your heart rate is going to spike, and you're potentially going to be more likely to have some arrhythmia. So typically, we titrate those medications about every 2 to 4 weeks until we come down to a new level, or we come off the medication altogether. And specifically for sotalol, if you're not having any arrhythmia, sotalol is an antiarrhythmic and a beta blocker. Some patients may still need a beta blocker because they've had a heart attack or they need it for some other reason. In those patients, we may take you off sotalol and put you on one of the other potentially more conventional and less dangerous beta blockers. So if you have history of coronary disease, you may have to stay on beta blocker. If you have other dangerous arrhythmias, from the bottom chambers of the heart, we may need to leave you on amiodarone. And if you have high blood pressure, you may need to continue to use your calcium channel blocker like diltiazem or verapamil, or a beta blocker to help control your blood pressure, and may end up having to stay on it. Now, as far as the blood thinners, typically we continue everyone on blood thinners for about 2 to 3 months after ablation. And then at 3 months, we make a decision based on whether or not you're still having arrhythmia and your risk profile. If you're still having arrhythmia, we suggest you stay on the blood thinner. If your risk profile is such that you're still at risk for forming that blood clot in the left atrial appendage, we may want to keep you on the blood thinner at that point in time. This just lists the typical symptoms of stroke. Do you have a droopy face? Can you raise or feel your arms or your legs? What is your speech like? There are interventions for patients with stroke now. And so if you have any of these symptoms, it's very important to come to attention as soon as possible, because we may be able to limit the size of your stroke. But ideally, we want to prevent stroke. And so depending on how many of these risk factors you have determines your risk of stroke. particularly if you have history of heart failure, high blood pressure, if you're a bit older, if you have history of diabetes, and if you've had a previous stroke. In Canada, we recommend blood thinners if you're over 65, or even if you're younger than 65 but have any of these risk factors. These are the medications we typically use to thin your blood. And while we cannot prevent you from participating in contact or high-risk sports while you're taking the blood thinners, you have to be cognizant of that, protect yourself, wear a helmet and whatnot. There is a significant risk of bleeding should you have an injury. We do, at the same time, want you to be as active as possible soon after ablation. For the first week, we don't want you to lift anything heavy or strain. For a couple of weeks, we don't want you to go to the gym. But after that, we do want you to become more active. And again, if you're participating in one of our virtual cohorts, you will have formal exercise advice from a trained professional. Depending on the activity, you may want to wait until you're off blood thinners. And again, being on antiarrhythmic agents and beta blockers may make it more difficult to exercise, but they shouldn't prevent you from being able to at least trying to exercise. Now, one of the questions was, can I use a blood thinner as a pill-in-the-pocket approach? And what else can we do to prevent stroke? So it's important to know how we document AFib. I already talked about the fact that atrial fibrillation has to last at least 30 seconds. We need to be able to monitor whether or not you're having atrial fibrillation with either consumer devices, such as LifeCore cardio devices, Apple Watches, etc., ECG machines that you can see here, or longer-term monitors, implantable monitors, patch holters, conventional holters, or what we do now is, again, using this novel Garmin device, either a bra in women or a chest band, either in women or in men. We can monitor your rhythm over a long period of time and use it as a holter. And using this device, we're able to tell whether or not you're having arrhythmia. Whenever you have an episode, you can transmit your symptoms, and I can look on my end and see what your rhythm was, kind of above and beyond the holter. We do know from studies that the higher your risks, the more risk factors for stroke you have, and the longer your episodes, your risk of stroke goes up substantially over time. So patients at highest risk for having the longest episodes are at greater risk. And currently, there is a study called REACT-AF. In this study, patients are being randomly assigned to either taking blood thinners driven by a device that tells them whether or not they're in atrial fibrillation, or taking them continuously and kind of using this protocol. So if you have arrhythmia, you start taking the medication, you take it for a month, and then if you have had no further arrhythmia, you stop taking it. When that study reports, we'll find out whether or not taking a blood thinner as pill in the pocket is a reasonable approach to anticoagulation. I also want to mention that there is another way we can prevent stroke, and that is by placing a plug into the left atrial appendage. There are two devices currently available to us, a Watchman device and an Amulet or an Amplatzer device. That's what these devices look like. The procedure to put them in is similar to ablation in a sense that we put you to sleep. We actually do a transesophageal echo while we're doing it, while you are asleep. I put a catheter into the left upper chamber of your heart and leave one of these plugs. The plugs are there to block off the entrance of the left atrial appendage and prevent blood clot from the left atrial appendage from ever causing a stroke ever again. Very safe procedure, low complication rate. In some higher risk patients, we're able to do it at the same time with atrial fibrillation ablation. And it's certainly something that you can ask us about at your visit with one of us or one of our nurse practitioners. Typically, we use it in patients with 2 or more risk factors for stroke. At this point, we do it in patients who have contraindication and cannot take a long-term blood thinner. And most will need to take 1 to 2 agents like aspirin and Plavix for a few weeks after the procedure, but then they'd be able to stop. And we're currently recruiting study patients. So these are really high-risk patients with 4 or more risk factors who will continue on blood thinners, and we're trying to see whether or not the device helps prevent stroke above and beyond blood thinners. In those patients with 4 or more risk factors, the risk of stroke even though they're taking a blood thinner, still about 10% over 5 years. And so we want to see if using a device in those patients gives them additional protection. And that's really all I had to say today. I apologize. I think I ran a little bit over time, and I see that we've received a number of other questions. I apologize for not being able to tackle those questions right away on the chat. But what I would like to do is go over these questions and hopefully schedule another webinar to follow up again in probably another month. So please look at our social media, look at our website. When you come to see us in clinic, let us know what other questions you have. We're looking at, how else do we disseminate this information? We might be able to package it into a blog, and we'll certainly make these videos available to you. And for those of you who would like to take note of the QR code will take you to a Linktree site that has links, to all of these resources, including the videos. All right. Thank you very much. And we'll take it from there. I think I did more than 10 questions.